Well, good evening. Thank you all for joining us. This is the uh, webinar on new technology for occipital cervical fixation, presented to you by the Cervical Spine Research Society. I'm very pleased to co-moderate this with Dr. John Heller. A couple reminders. We do have the 52nd annual meeting of the CSRS coming up this December in Chicago. Abstracts are currently being accepted for another few weeks until April 24th. So we encourage everyone, if you have any research to submit, we would love to see it at the 52nd annual meeting. We also want to remind people that the Clinical Spine Surgery Journal is the official journal of the Cervical Spine Research Society. We'd encourage you to submit any papers focused on cervical spine to the Cervical Spine Surgery for possible inclusion in the upcoming issues. We're also, with the CSRS, becoming involved with social media, so we encourage you to follow us on the various formats, whether it's in LinkedIn, Instagram, X, or Facebook, and those are all the various identifications of CSRS on those societies. So please give us a follow so we can keep you up to date on any other upcoming events with CSRS. And then, as I mentioned, CSRS has a YouTube channel. This is a repository of presentations put on either at CSRS, the instructional course, or webinars like this. There's a growing amount of information there, so please give it a look and subscribe to the CSRS YouTube channel. So tonight, this is just our agenda for the evening. So Dr. Heller and I will lead off. Then we'll have Dr. Heller will do a review on anatomy. I will talk about how I do it for occipital cervical using both freehand and Fluoro-assisted. And then we're really pleased to have Ilyas Aleem from University of Michigan to talk about how he does it with navigation assistance. And we're especially proud to have Dr. Nick Theodore from Johns Hopkins, one of the fathers of robotic spine surgery, give us his take on how he does it using robot assistance. And then we'll finish up with some case presentations. We have one from Dr. Heller, and if time permits, I have one as well. And we'll all the panelists will be there for a live discussion.
Good evening. I'm Dr. Nicholas Theodore, coming to you from Johns Hopkins, where we just witnessed the solar eclipse a few minutes ago. If you didn't see it, it was amazing. I'd like to thank Drs. Heller and Wright for the opportunity to address you this evening on the topic of robotic technologies in craniocervical fixation. These are my disclosures, which are relevant. I think forevermore, the field of spinal surgery and certainly cranial surgery changed with the advent of image guidance, the ability to see in three-dimensional space where we are during a procedure. And we have been a little slow on the uptake to adopt this technology. But if we're honest, we realize that putting in hardware every day, as I have for the past 30 years, we're not as good as we think we are. This large meta-analysis showed about a 9% breach of screws. When you look at overall accuracy in the cervical spine, which is what we're talking about, conventional accuracy is about 69%. We get up to 73% utilizing fluoro, and then up into the 90 percentile range of accuracy when we use three-dimensional navigation. I have a large experience with occipital cervical fixation. This was a study I published a number of years ago, my first 120 patients, and now have over 200 patients in the study. And what I will tell you is that image guidance has become a critical part of the workflow, and I would argue now that robotics will add to that. But what we're talking about in these cases really is rigid fixation across the craniocervical junction, and that requires a bony arthrodesis. So here you see fibular allografts. We see here a patient postoperatively with instrumentation in place, and then a solid arthrodesis where the fibula has been placed between the occiput and C2. The neat thing about these cases are that they are complex in that we have to restrain multiple areas of motion, and the geometry is very complicated and different in every single patient, which gives us the opportunity to do something new for each patient. One size does not fit all, and figuring out how do we restrain motion and get a solid arthrodesis is really the key. Positioning the patient is critical. This is the position the patient is going to end up in for the rest of his life. So you absolutely need to take time and understand where they are, where their head is in space. Are they able to swallow? Are they looking up or down? And making sure that we get that perfect at the time of surgery. We're now at a very exciting time in spine surgery. We have advances in imaging, surgery, and robotics. We, of course, have image-guided surgery, which we've talked about. We have surgical robotics, and now we have really the nexus of these three things with image-guided surgical robotics, which is I'm going to talk to you about here in a minute. What we're talking about is taking a trajectory and finding a perfect trajectory and then having a robot take us there in space. And with a rigid arm, we're able to do things percutaneously. And we do this every day now in the thoracic and lumbar spine. And my entire practice has become robotic. And I'll talk to you about some cases in the craniocervical junction as we expand the usage of this technology. The robot really is meant to be more of a cobot to bring it into the field and allow us to do what we need to do without being obtrusive. So again, the robot rolls in, we're able to do our surgery, and it rolls out. First case I'm going to show you is a 60-year-old gentleman who had a collision with a wave and sustained a bilateral hangman's fracture and also central cord syndrome. So he had myelopathy on examination. So he required not just a fusion, but a decompression. You can see the central cord here with ongoing compression of the spinal cord. So we had an opportunity in this case to do something a little bit different, and that is to fixate directly and repair the fracture directly utilizing a robot. And the right-hand panel, you see the robot in place and watching in real time as we drill across the fractured segment and then instrument it. Again, something you could do with image guidance, but with the rigidity of an arm, it really gives you a lot of confidence that you're going to hit that target and make it perfect. So again, this is a one usage of a robot with a rigid arm to allow us to take a non-traditional treatment for a fracture like this. You can see, again, as we planned these screws at C2 to go across the fracture segment, and then ultimately, being able to pull those, the piece, if not together, close enough that it will heal on its own. And this patient went on to a solid arthrodesis. In surgery, we can get a three-dimensional spin with an imaging device that allows us then to translate into the usage of the robot. This is another case of C12 transarticular screws, where again, we are able to plan. And the nice thing about that is understanding where the vertebral artery is, where the canal is, and how long and large of a screw can you get in. So we found that our hardware has become much more robust utilizing robotic technology, because it's not, let's get the smallest, safest screw in, but let's put a bigger screw in because we know we're going down the proper trajectory. This is another case here of joint degeneration at C12 with intractable pain and doing a transarticular screw fixation. Ultimately, this technology will also allow us to do things that we're not doing routinely, which would be something like this. We did a case, which I don't have the images for, which is occipit to C1 screw, and even a C2 to the occipit screw, utilizing a unique trajectory with the addition of robotic guidance and the rigidity of the arm. So ultimately, this opens up a new avenue for us in the treatment of these patients. At the end of the day, the occipital cervical junction really is an exciting surgery. I find it probably the most enjoyable thing that I do, because every single case is different. Nothing supplants, number one, knowing the anatomy, that patient-specific anatomy. Number two, accomplishing the goals of decompression, and then ultimately fixating that patient in a situation such that he can participate in life without further disability from restraint of motion. So thank you very much for your time and attention.
Well, I thought this was an amazing webinar. I really appreciate the working with John, and I really appreciate the input from Dr. Theodore from Johns Hopkins and Dr. Aleem from University of Michigan, looking at these new technologies. I think they are bringing extra tools to the field and making our surgeries better. So, John, unless you have anything different, I'd just like to thank everyone for participation and a wonderful webinar.
Yeah, thanks. It looks like we had a good crowd, and hopefully everybody enjoyed it.
Yeah, thank you for putting together, Neill.
Maria, thank you for cobbling all this together. Close it out. Have a good night, everyone.
Thanks.
Yeah, thank you, everybody.